And again, what we continue to maintain and insist is that the Serum Institute had given a certification that shelf life could be extended to the 13th of July. So, but we should look at a bigger picture, because vaccines are only now beginning to be rolled out on the continent. And the issues of whether countries use vaccines quickly will come up over and over. I mean, that this is not just going to be the first time. The doses that were shipped out, they were very early doses to actually say test the waters, and bigger doses will come in. But the key thing here is to focus on what Malawi did is within about 2 weeks or so, they were able to use up about 85% of the vaccines. That is very, very good news. The other thing we should be focusing on is preparing countries in such a way that they just replicate what Rwanda did. So within a week or so, Rwanda was able to use all its 290,000 doses of vaccines. I mean, that speaks to the reflexes that we should have in times of this pandemic. This is not an immunization against polio or cholera or measles that we can take time to do it. It has to be at speed and it has to be at scale, which means every member state must be prepared, such that if they say you get vaccines today, you should be able to mobilize and get yourself into full swing and start using the vaccines, so that we don't get into arguments of who delivered the vaccines, who didn't use the vaccines, and whatever. I think it doesn't reflect the spirit of the urgency that we are in now. And if countries, again, this is my general advice, not to the Malawi situation, if any country receive vaccines and they find themselves in a position that they anticipate they cannot use it, they make a call to whoever donated early so that they can redistribute. DRC did just that a few weeks ago, and the vaccines were taken out of that country and redistributed. So I think we are in a situation where the vaccine market is extremely, extremely limited. The virus is raging, and we should just use all the tools in our disposition when they're available to continue to fight this the pandemic.
Thank you for that. We have a question from Bert Mensing from the ZDF German TV based in Nairobi. And so Bert says, is there any news about how and when member states will receive more doses of vaccines? And he's asking this in the context of some countries having already used up their available allocations.
So as I've said this week, and last week and the previous week, those doses that were distributed extensively across the continent came from the COVAX facility. And I'm sure you do, all of you on this platform do briefings with the COVAX facility in Geneva. Is to really, I mean, they are better placed to address that question with respect to when countries can expect additional doses there. I can only speak authoritatively with respect to the vaccines from the AVAC mechanism, which is the African Vaccine Acquisition Task Team. And just repeat what I've said many times, that vaccines from that facility will begin to be distributed beginning the first week of the third quarter. And so we are basically about 2 months from that when those vaccines from the Johnson & Johnson will begin to be distributed. And we are preparing, working very hard to make sure that that is delivered. And with some luck, some early doses may be available, but not in large amounts. The vaccine situation is extremely challenging for us as a continent. We remain hopeful also that the positive signals that we are hearing from countries that that had acquired large amounts of vaccines are ready to begin to redistribute. I think I read that the United States is ready to redistribute about 60 to 80 million doses of vaccines. France has also committed to redistributing some, and we just hope that that can be done quickly, so that we do not run into a gap between now and August when our doses from Johnson & Johnson will begin to kick in.
Thank you for that. Let's go live and invite Henry. And Henry is a freelancer with the Washington Post. Good morning, Henry. Hello, Henry. All right, it looks like we're having problems connecting with Henry. Let's move on to Paul Adepoju. Good morning, Paul.
Hello, good morning. Can you hear me?
Please. Yes, we can hear you. You are from the Lancet. Please go ahead with your question.
Yeah, thank you very much. Dr. John, you said the strain that was first identified in India will eventually spread across Africa. Why is this so, and what are the peculiar implications of this prediction? And earlier today, the WHO launched the One Health panel. How is Africa CDC working towards breaking the easy crossover of zoonotic infections to humans in a number of African countries? And for the Nigerian representative, I would like to ask, when was the data gathering in Nigeria done, and what influenced the study site selection, considering several epicenters of the COVID-19 pandemic in Nigeria were not included? Thank you very much.
Hello, Paul. Can I just ask? Yes, Paul, can I just ask you to repeat that last question so we can start with that and give it to the representative of Nigeria who's online?
Okay, thank you. So I asked that when was the data gathering in Nigeria done, and what influenced the seroprevalence study site selection, considering several epicenters of the COVID-19 pandemic in Nigeria were not included?
Thank you. Can we go over to Professor Egumbo from Nigeria?
Thank you very much, Chair, and thanks, Paul, for that question. The survey in Nigeria ran in Lagos between September 21st and October 1st, and in the other states between September 27th and October 27th. We have done the survey completely in 4 states: in Lagos, in Enugu, in Gombe, in Nasarawa states. But in selecting the states, we sought to get at least 1 state in every geopolitical zone. In terms of our surveillance data, we also tried to balance states with relatively high reporting of prevalence, and as well as those with lower rates of reporting. We feel the current spread is reasonable, but are quickly making inroads in having surveys in additional states. We have concluded data collection in Sokoto in the Northwest, and we are preparing for data collection in South-South states of Delta, in the central state of FCT, and in Kano State. So indeed, we think that gradually would have had a sufficient of states covered through the survey. Again, thanks for the question. Over.
Thank you. Thank you very much, Prof. Maybe at this point, let me also give an opportunity to the other country representatives to speak to us a little bit about their participation in this seroprevalence survey. Let me start with Dr. Mohamed Bello Barry, the representative of Sierra Leone. Dr. Barry, in 2 minutes, please give us the main highlight points that you want people to take away from this press briefing today.
Yes, so for Sierra Leone, I think I will talk about the methodology that we did. We did a national based serosurveillance, which we randomized. We took the Statistics Sierra Leone enumeration areas that they used to conduct the DHS surveys, and we randomized those enumeration areas. We selected 120 of the enumeration areas. Then also within each enumeration areas, we randomize, have 10 households, and in each household, we surveyed 1 to 2 people in the household, and we followed the age strata that was given, and then did both the serosurveillance and did some interviews on terms of exposure, symptoms, and other things. So basically, that's what we did, and it's a representative of the whole. Sierra Leone is a small country compared to Nigeria and other countries, but like survey and sampling, we're able to sample each district in the country. Thank you.
Thank you very much, Dr. Barry. Can we have Dr. Henry Kyobe-Bosa, the representative from the Republic of Uganda? In 2 minutes, please, Doctor. Can you tell us your participation in this survey?
Thank you so much, Chair, and thank you so much, Dr. John. The methodology largely mimics what was done in Sierra Leone, but I will specifically go on to the findings, where from the response data we see that here in Uganda, the disease, COVID is predominantly a disease of the male, contributing amongst the reported cases. But what we see here in the survey, what we got in the survey, that the findings between male and female are near even, around 20%, which is showing exactly what where this means and where this comes from. But of course, the other thing is that with in Uganda, we see that the virus penetrated much deeper than actually we previously knew. And this speaks to the importance of this kind of study. The methodology was quite representative, close indeed, where we used enumeration areas that are used in the national census, and we randomly selected 215 enumeration areas. We were sampling, and in each household getting between 1 to 5 individuals of different age groups. Both gender represent. Our population pyramid is much skewed, that fewer and fewer older people above 60. We took anyone that we found in a household, and as you see that we have, of course, we don't have complete data here displayed, and that gave us a very good picture and understanding on where we are. There were no big surprises, of course.